Hello everyone and welcome to RAAONLINE. I'm Dr. Abinaya. I'm your pediatric faculty at RAAONLINE's Nielsen-based pediatric teaching course, which is otherwise referred to as the Pediatric Pulse program. So we are in the chapter discussion on genetics, and here this video lecture is on uniparental disomy and genomic imprinting, where I'm going to describe what is uniparental disomy and the two most common disorders which come under these. We know there are some 8 to 9 disorders of uniparental disomy, but I'm going to talk about the two most common, that is Prader Willi and Angelman Syndrome. And two microdeletion syndromes I'm going to refer here. One is DGEORGE and another one is Williams syndrome. So all the salient points will be discussed, and I'm going to keep it short so that you will remember the important points which are very important points for the exams. So first I'll give an intro of what is this uniparental disomy and genomic imprinting. So we know humans inherit two complete set of chromosomes, one from the father and one from the mother. So what happens is, most of the times all the in one pair, two chromosomes of both of them are active. Some cases only one copy will be active, and that copy, if it is only that copy, if it is active, it means that based on which parent it has been inherited, say it has been inherited from the father or from the mother, and only that is inactive, it is called as genomic imprinting. And genomic imprinting, we will know why, because even when the genes are inherited, they will be given a stamp to the particular gene by adding a methyl group to it. So that is called as methylation, and this is what is the basis of a methylation fish or the methylation CGH, where we will be able to identify this genomic imprinting. So what happens is, why are we worried about this uniparental disomy or genomic imprinting is, so even if it is an autosomal recessive disorder, if the child, if the proband derives this particular gene only from the father, he will have two copies of the same gene from the father or two copies of the same gene from the mother. So if the gene is defective, what will happen? He will have two alleles which are defective, and even though it is an autosomal recessive condition, he will be able to manifest that condition. Are you getting the point? So this is a very, very sporadic occurrence that occurs during early fetal development, right? When both chromosomes of an individual come from the one parent, that is called uniparental disomy. There is something called as uniparental isodisomy and uniparental heterodisomy. Iso means same. See, here it is uniparental isodisomy. So this is father, this is mother. So this is the resultant fetal gene. So what happens, this gene is both from the father only, and here what happens is the resultant two chromosomes, they are different, so it is called as heterodisomy. Here contrary to this, what happens is both genes are derived from the parent, but both are very, very similar. So this has resembled only one chromosome of this pair. So this is called as isodisomy. So how diseases occur in uniparental disomy is when that parent is a carrier of an autosomal recessive gene, and if that abnormal gene is inherited into two copies, what happens? The child will be able to manifest that disorder. So we are concentrating on these two syndromes only, Prader Willi and Angelman syndrome. Both are uniparental disomy concepts, although Prader Willi and Angelman can be inherited even without uniparental disomy, just by deletions, just by other structural rearrangements. Prader Willi can occur, Angelman syndrome can occur. But one of the modes of inheritance for Prader Willi and Angelman is uniparental disomy. It occurs in chromosome 15. Prader Willi syndrome, here 25% of the cases occur due to maternal uniparental disomy. Here the paternal gene is not there. So paternal inheritance is not there in Prader Willi. Angelman, only 5% of cases occur due to uniparental disomy, and that is because of paternal UPD, paternal uniparental disomy. So what happens in Prader Willi syndrome is, there are some paternal nucleolar RNAs. Okay, so paternal deficiency of nucleolar RNAs. What happens in Angelman syndrome is, there is a maternal gene which is the UBE3A gene. So the loss of this UBE3A gene is seen in Angelman syndrome. So this can very well occur without the uniparental disomy also. Just by the UBE3A gene, if it is deleted also, Angelman syndrome will happen. Only 5% of the cases of Angelman is due to UPD. Understood the point? So just know what is uniparental disomy, what is genomic imprinting first. So 2 copies should come from 1 copy from the father, 1 copy from the mother. If both copies come from one parent, it is called uniparental disomy. Imprinting means you will where it is inherited from. So because of the methylation group which is attached to that particular gene, you will know if it is paternal disomy or maternal disomy. Got it? This is very basic form. I don't know how much even I can simplify this. So this is what you need to understand from UPD. So coming to why this UPD occurs. So just a brief note of why UPD occurs is usually some cells, they arise as trisomic cells. As a rescue, as a prevention of continuation of trisomy, what happens is if there are 3 copies of chromosome 15, say, so there is chromosome 15, 15, 15. So 3 copies are present. The body itself is trying to avoid one of the extra copies of chromosome 15. So by mistake, what it will happen is it will delete the father's chromosome 15 or the mother's chromosome 15. So both will be from one parent. So that is how uniparental disomy will start. So it's a random loss of one particular chromosome. It is starting as trisomic cells. As a trisomy rescue, this one particular parent's chromosome 15 will be lost. Okay. So I told you Prader Willi and Angelman are what we are going to discuss in this presentation. Apart from Prader Willi and Angelman, there are other disorders also which can occur due to uniparental disomy. Interestingly, some type 1 diabetes, Temple syndrome, Beckwith-Wiedemann, Silver-Russell syndrome, pseudo-hypoparathyroidism, Wang syndrome, all these can also occur due to uniparental disomy. So let me start the discussion on Prader Willi syndrome. So Prader Willi syndrome has a very unique feature because initially in the newborn and the infantile period, they are very, very weak babies. So hypotonic babies, weak cry, failure to thrive babies, they will have feeding difficulties. Once they enter into the childhood, what they'll happen is they'll have hyperphagia. So because of this hyperphagia, their weight keeps increasing. They will have this truncal obesity. So although they are short, they'll have huge tummies and their short hands, short feet. Hypogonadism will be there. Very small penis, micro penis will be present. Bilateral cryptorchidism will be present. If it is in females, the labia is very, very small. So Prader Willi syndrome, I will show you how it progresses across various age groups. So typically these children have a developmental delay. So they have both motor delay and language delay. They have learning difficulties. They have behavioral issues. They have autistic features, ADHD. Even as adults, they can have psychosis. So we have to identify this developmental delay. Coming to endocrine abnormalities, they have growth hormone deficiency and they have gonadotropin levels are also low. They can also have central hypothyroidism. One more important feature in Prader Willi is this obstructive sleep apnea. So Prader Willi syndrome, coming to the phenotype of this, so these children have typical hypopigmentation. Even in Angelman, they have this silky whitish hair, etc. So they have hypopigmented face and hypopigmented hair. They have almond-shaped eyes and usually they have this esotropia or exotropia. Myopia can be present. Very thin lips, temple narrowing. So they have a quite crowded face. And they might also have hip dysplasias and bone fractures due to osteoporosis. So this is a textbook picture of Prader Willi syndrome. A short child, obese child with truncal obesity, micro penis, and look at the eyes. So almond shaped eyes, the crowding of facies, a broad nasal bridge and very narrow temples and thin lips. So these are all the typical facies of Prader Willi. Here you can appreciate micro penis and cryptorchidism also. This is the varying at different stages. So initially they will have hypotonia, poor feeding, failure to thrive child, feeding problems, and during childhood hyperphagia will be there. They will have intellectual disability, they have behavioral issues, etc. In adulthood they have metabolic syndrome, type 2 diabetes and obstructive sleep apnea. So most of the features that we saw are described here. These are some of the features that we just saw. can go through it later. So there is diagnostic criteria for Prader Willi syndrome, which is divided into major criteria and minor criteria. You need not worry about all these diagnostic criteria. I have just put for reference sake only, right? So what you need to understand is the salient features. So just go back to this particular tabular column. So I think this and this tabular column, if you know, it is fine. And about the facies. So nutritional phases, again it changes. See, from the birth to 9 months, they have difficulty in feeding. So beyond 9 months, their feeding improves, their appetite improves voraciously. So they start gaining weight, and they are hyperphagic, and they rarely feel full after their meals. And coming to the Prader Willi syndrome, only 25 to 30% is due to UPD, that is uniparental disomy. This is maternal uniparental disomy, and remaining 70%, what happens is there is a gene deletion at 15q11, right? So 15q11 gene deletion is causative for 70% of Prader Willi syndrome. And Angelman syndrome, I told you 5% is due to UPD, paternal UPD, 70% is due to the 15q11 gene deletion. The gene which is responsible is the UBE3A gene. So how do you test for Prader Willi syndrome? So you have to have the methylation study. Fish sometimes will not be, will not show these methylation studies. So methylation specific fish or a chromosomal microarray will be needed for Prader Willi syndrome. And genetic counseling for these patients is, what is important here is, this is mostly a de novo deletion. So the risk of sibling is going to be less than 1% only. And management, of course, in early infancy, we have to concentrate on feeding. In late infancy, we have to concentrate on reducing the weight. So one thing is, these children have short stature. So this is one of the indications for growth hormone therapy. So we start growth hormones in Prader Willi syndrome also. It is one of the FDA approved indications. And global developmental delay, behavioral issues, it needs developmental pediatricians opinion, and there can be central hypothyroidism, there can be hypogonadotropism, so needs to be checked early, and sleep studies to rule out obstructive sleep apnea is needed. So growth hormone is started for these children, but if there is an obstructive sleep apnea, try to avoid growth hormone. And if there is obesity, diabetes mellitus already, you cannot start growth hormone in Prader Willi syndrome. So coming to Angelman syndrome. Angelman syndrome, we know that they are called as happy puppets. So these children, they have, like similar to Prader Willi, this is also, they have delayed development. So there is a global developmental delay, intellectual disability will be present, speech delay will be present, but they are very, very happy, excitable children. So frequent smiling, laughter, hand flapping movements will be present in these children. They are very, very hyperactive. And similar to Prader Willi, they can also have unusual fair skin, light hair, some bone abnormalities like scoliosis can be present in these children. So Angelman syndrome affects 1 in 12,000 to 1 in 20,000 people worldwide. It is surprisingly increased in Denmark, in Europe. Exact incidence of Angelman syndrome has not been studied in India so far. So clinical symptoms more or less similar to Prader Willi, developmental delay, speech impairments, epilepsy can be there, ataxia is there. So depending on the name, that is happy puppets, so frequent smiling, laughter, hand flapping, hyperactivity can be there. Microcephaly, they appear very fair skinned individuals. So here the gene has been studied. It is UBE3A gene, that is the ubiquitin gene. So this ubiquitin gene abnormality, why there is an abnormality here is because here is paternal UPD, paternal uniparental disomy of this gene. This gene to be established in the brain, we need maternal copy also. So the maternal copy will be active in the certain areas of the brain. Since this is lost, it causes severe global developmental delay, intellectual delay in these children. So 3% to 5% is due to paternal disomy, otherwise it could be due to deletions. And the genetic variations, the phenotypic variations can be based on what is the genotype. So if it is a Uniparental disomy, it is actually mild phenotype. In case there is a large deletion, okay, so there is a 15q, 11, 13 deletion, so entirely UBE3A gene is deleted completely. If it is a large deletion, it is a severe spectrum. The child has severe global developmental delay, severe seizures, severe microcephaly, etc. Okay, so based on what is the genotype, the phenotype will also vary. So to identify this, of course, we need methylation specific fish. A chromosomal microarray will be needed, and treatment predominantly it is supportive only. So supportive management of seizures here for hyperactivity, physiotherapy, occupational therapy, feeding difficulties, all these have to be addressed. Very, very importantly, in seizures, we have to avoid carbamazepine, vigabatrin and tiagabin in these children. So that is going to exacerbate seizures. So these are important. So now let me move on to the microdeletion syndromes. So the first microdeletion syndrome that I am going to discuss is the Digeorge syndrome, otherwise known as velocardiofacial syndrome, or the chromosome 22q11.2 deletion syndrome. So Digeorge syndrome is it is one of the most common T cell disorder, and it has a very high incidence, that is 1 in 3,000 births in the United States. Here what happens is, so development of third and fourth pharyngeal pouch is disrupted. So what happens here is the structures that develop from these pharyngeal pouches, like the thymus, the thyroid and the parathyroid gland, those are abnormal here, and 75% of these children have thymic hypoplasia. 1% has thymic aplasia, so there is complete absence of lymphocytes. So depending on the hypoplasia, the immunodeficiency will also result. So it will result in very severe to severe T cell deficiency. So third and fourth pharyngeal pouch, one is we know thymus, thyroid and parathyroid. So thymic hypoplasia or thymic aplasia, if there is absence of parathyroid glands, there is hypocalcemia. Next is CVS, cardiovascular abnormality. So the conotruncal abnormalities are very, very common in these children. So most of these children have abnormalities of the great vessels, like right-sided aortic arch, conotruncal abnormalities, atrial, ventricular, septal defects, etc. These children also can have some GI abnormalities like esophageal atresia, bifid uvula, etc. So the typical Digeorge facies will be, they have a very small mouth, microstomia with very short upper lip, short philtrum, hypertelorism, and they have an anti-mongoloid slant. So these children can also have feeding difficulties because of the bifid uvula, because of the velopharyngeal insufficiency. They can have varied laryngotracheal abnormalities. They can also have hearing loss. They can have CNS abnormalities like pachygyria, etc. And these children can also have other genitourinary abnormalities, skeletal abnormalities, etc. So there is a wide range of abnormalities that we see in Digeorge syndrome. It is an autosomal dominant disorder, but the phenotype is highly variable. So 30% of these children of 22q11.2 can be associated with this association, which is called as the Charge syndrome. So Charge stands for, C stands for coloboma, H stands for heart disease, A stands for atresia of Coyne, R stands for retarded growth, G stands for genitourinary abnormalities, and E stands for ear anomalies. So most often based on Charge syndrome, you can write the previous features also, like C for coloboma, heart disease, etc. And genitourinary abnormalities are present, growth retardation is present, gastrointestinal abnormalities, and even ear abnormalities, that is hearing loss. So most of the features you can write based on the Charge mnemonic for Digeorge also. So what we are worried about is the thymic aplasia, which is resulting in the T cell deficiency. So if it is aplasia, the presentation is just like SCID, severe combined immunodeficiency. So from birth, the child is susceptible to varied infections like fungal, viral, etc. And management is only, you have to, identify this in a timely manner, and this disease is fatal. Just like SCID, it is fatal without any treatment. And the diagnosis, of course, at birth, if you identify, first look at the absolute lymphocyte counts, and initially they are only moderately low and then they keep decreasing. Immunoglobulin levels are usually normal in these children. So FISH and chromosomal microarray can identify the 22q11.2 deletion in these children. So treatment wise, it is the immunodeficiency can be treated by hematopoietic stem cell transplants, and it is an immunodeficient child. So live vaccines have to be avoided until there is adequate T cell counts. So this children, of course, stem cell transplant is curative. Till then, for cardiac anomalies, cardiologist follow up. You take plasma calcium levels, and if it is low, calcium supplements have to be given. Thyroid function testing has to be done, and for developmental delay, for motor delay, referral for early intervention. And usually these single genes or single gene deletions disorders are usually de novo entities, and the recurrence risk is quite low. So coming to another disorder, which is Williams syndrome. So here, Williams syndrome, the gene deletion happens at chromosome 7q11. Here, the gene which is abnormal is nothing but the elastin gene. So elastin is nothing but it is a gene. The defect is generalized because it is responsible for most of the cardiac, most of the vascular anomalies which we see in the Williams syndrome. The most common cardiovascular anomaly is a supravalvular aortic stenosis that is seen in Williams syndrome. And apart from the supravalvular aortic stenosis, there can be peripheral pulmonic stenosis, renal artery stenosis. Typically, any artery can be affected because of the elastin abnormality, but most often this renal artery, supravalvular aortic stenosis, mitral valve prolapse is seen. So this is also a quite common disorder, 1 in 7,500 to 1 in 10,000 live births. This is also inherited in an autosomal dominant fashion. Most often there is a de novo gene deletion of the elastin gene. And so Williams syndrome, typically these are called as the elfin facies. So there is a broad face, okay, so broad forehead. There is a puffiness around the eyes that you can see here, and the nasal bridge is depressed. There is a long philtrum for these children. There is wide gap between the teeth, prominent lower lip, and small chin. So this is a elfin facies that is typically seen in Williams syndrome. Cardiovascular features, the most common feature, as I just mentioned, it is the supravalvular aortic stenosis. Typically, any artery can be involved, but after supravalvular aortic stenosis, it is pulmonary artery stenosis. Other valvular abnormalities can be seen. Hypertension is seen in Williams syndrome. So these children can also have developmental delay and intellectual disability, learning difficulties, etc. Williams syndrome children are also very, very friendly, hyper sociable children, just like the happy puppets. Even Down syndrome child are very, very hyper sociable. So these children are also like that, and they have growth and developmental issues like IUGR, failure to thrive, feeding difficulties, etc. Because of the elastin gene abnormalities, there is joint hypermobility, skin will become very, very lax. They can have inguinal hernia, umbilical hernia, and rectal prolapse. They can also have spinal abnormalities. Some endocrine abnormalities can be seen in Williams syndrome. Typically, it is the hypercalcemia that is due to hypothyroidism. So do not forget these two. Precocious puberty is also seen in a subset of Williams syndrome. Some gastrointestinal problems like constipation, GE reflux, you can remember. So these children are very, very hyper sociable. They have reduced brain size. They have this elfin facies. Elfin facies typically the starry sky eyes, broad nasal bridge, very, very thin lips, and a long philtrum. And they have hyperactivity. They have defective attention issues in these children is present. So overall short stature, IUGR children, and two most important thing is do not forget about the cardiovascular issues that these children face. And the endocrine issues is precocious puberty and hypoparathyroidism, hypercalcemia. there can be some depigmentation and premature graying of the hair also. So diagnosis is just based on clinical suspicion, and of course we need to have a chromosomal microarray to identify the gene deletion, chromosome 7q11. And supportive care is doing an echo, finding out any cardiac anomalies, do a plasma calcium level, rule out hypercalcemia, developmental assessment, puberty assessment is necessary for these children. So there is no cure, only supportive multidisciplinary care for these children. Cardiac monitoring, speech, physiotherapy, occupational therapy, educational interventions, endocrine follow-up and psychological support. So lifelong follow-up is necessary for these children. So because of proper supportive care, they have a relatively good life expectancy. So this is about Williams syndrome. So with this, we come to the end of this video lecture. So if you have any other topics in your mind, please do write to us and we will cover that also. Thank you for your patient listening. Bye-bye.